My name is Marvis Doster, and I'm a certified addictions registered nurse. In September of 2017, I traveled throughout the state of North Dakota as part of a grant that was given to Heartview Foundation and Community Medical Services in order to provide information on withdrawal management to 7 jail sites throughout the state. I enjoyed the training very much. In this presentation, I'm offering that information for continued use of development of a relationship between treatment services and our jail services. The contact information for Heartview Foundation and Community Medical Services can be found at the end of this presentation. Thank you. The objectives of this training is to understand the basic symptoms of intoxication and withdrawal from substances of abuse, and participants will also gain the knowledge of the different settings and approaches that are available to safely withdraw people from drugs and alcohol. Participants will also gain an understanding of the assessment of persons at risk for withdrawal, the medications that are used to treat withdrawal, and other interventions that can be utilized to safely treat withdrawal from drugs and alcohol. The participants will also develop skills in monitoring for withdrawal and using assessment tools such as the CWA and the COWS, which are assessment tools we'll discuss as we go along with the information here, and the necessary documentation for these assessment tools. Participants will also develop some skills in assessment for symptoms of physical, mental, and behavioral problems that are associated with substance abuse and that may warrant referral to immediate medical or psychiatric interventions. Also, participants will be encouraged to develop knowledge of their community resources for the support in the management of withdrawal at their facility. Substance use disorders pose a very significant and expensive public health problem. Substance abuse affects not only, of course, the substance users, but their families as well, and the society as a whole. Through the use of drugs and alcohol, we've certainly seen increases in crime, in domestic violence, in highway fatalities, incarceration, and in healthcare costs. Certainly, any substance that alters perception or a person's mood or their ability to think or their cognition can be abused. But commonly identified substances of abuse include the ones we'll be talking about in this webinar: illicit drugs such as heroin, cocaine, methamphetamine, and marijuana; alcohol, which is the most common drug of abuse in our state; common prescription drugs such as amphetamines; narcotics, which are used to treat pain; tranquilizers, which are used to treat a variety of anxiety or mental health problems. Less commonly recognized prescription drugs are also misused, such as antidepressants and antipsychotic drugs. And over-the-counter medications commonly available without prescription, such as antidiarrheals, cold and allergy products, are also drugs that can be abused and have been abused by people requiring intervention and medical care and sometimes treatment services. Much of the information contained in this presentation comes from a publication from the Bureau of Prisons called Detoxification of Chemically Dependent Inmates. The guidelines were written in 2014, and much of the information contained in them is very useful in providing care to this particular population. In regards to some of the statistics provided in that document, substance use disorders are highly prevalent among inmate populations. Drug intoxication and withdrawal may be particularly evident at the time of incarceration, affecting an estimated 30 to 60% of inmates, depending on where in the country you're looking at statistics and the types of charges against those being incarcerated. But there is a wide range in the percentage, and many people who work in the field of incarceration realize that these numbers may be significantly higher. The Bureau of Justice Statistics report that an estimate 70% of all inmates at local jail facilities in the United States have committed a drug offense or use drugs regularly, and an estimated 35% were under the influence of drugs at the time of the offense. That also might be just at the very minimum. Many people I talked about this throughout the state of North Dakota agree that it's probably much higher. So what exactly is withdrawal management? Truly, it's a set of interventions that are aimed at managing the acute intoxication and withdrawal presented by people who are under the influence of a variety of substances. Withdrawal management seeks to minimize the physical harm caused by the abuse of these substances, and withdrawal management alone is not sufficient in the treatment and rehabilitation of substance use disorders. So really, it's just a very acute look and support services for withdrawal from these substances. But it needs to be just a part, a very small part really, of the referral to treatment services that's necessary to address the problems with drugs and alcohol. The process of withdrawal management consists of three basic components: evaluation to determine the type of withdrawal management that's necessary, then stabilization of the person that you're treating, and then fostering that patient's readiness for and entry into treatment services that are appropriate to address their problems. A management process that does not incorporate all three of those critical components is incomplete and inadequate for addressing the problems created by the substance use. Not all drugs of abuse produce significant withdrawal. However, anyone who discontinues substances on which they've been dependent on, such as stimulants, cocaine, hallucinogens, and inhalants, will likely produce some sort of psychological symptoms, if not physical ones. Withdrawal from these substances can be accomplished generally with really good support and ongoing assessment to determine if medical or psychiatric needs present and need to be addressed. The intensity of withdrawal cannot always be predicted. We'll ask questions of people, we'll get as much information as we can, but you still can't predict what kind of withdrawal people are going to experience when they stop using. The most addictive substances tend to make a slow and safe withdrawal from the substance more difficult. So often they're a combination of different substances in the body, which people tend to use now, a wide variety of things that we find in their bodies at the time of their admission to a treatment program or a withdrawal management facility or into a jail situation requires a great deal of observation of that person to make sure that they are being safely withdrawn from the substances in their body. Frequent clinical assessments along with indicated adjustments and necessary treatments such as medications are imperative in dealing with withdrawal in some people. Not everybody suffers the kind of withdrawal that can produce the very severe symptoms that might require medical intervention on a very emergent kind of basis, but every person that enters the incarceration under the influence or has been using drugs and alcohol need to have frequent assessment to make sure that they're not developing those symptoms. And if they are, appropriate action is taken. The substances that produce the most dangerous withdrawal syndromes are: number one, alcohol. Alcohol withdrawal can be life-threatening to people who are experiencing the most severe symptoms created by their dependence on this particular substance. Benzodiazepines also require close observation and present very significant withdrawal symptoms. And opiates, the narcotics, the prescription drug narcotics, as well as the street drugs such as heroin. Withdrawal from opiate narcotics is not generally considered dangerous except in pregnant women and the medically debilitated, but it does cause significant problems with the kinds of symptoms that people experience, as we'll discuss. Every effort should be made to adequately treat the signs and symptoms of alcohol or drug withdrawal, and that requires sometimes medical intervention and sometimes support measures and comfort measures. But adequate doses of medication to treat withdrawal is the safest route to take in reducing the risks presented by alcohol and drug withdrawal. There are wonderful medications available to ease people through this initial acute phase of their treatment, and it's imperative that we recognize the need for it and support people in this manner. Support and comfort measures that go along with the medication is what's vital in providing a safe environment and a safe process of withdrawal for people. Support from those around them who understand the process and understand what people are going through, and comfort measures to ease people's pain and misery are very important in having a positive outcome in withdrawal management. Frequent reassessment is necessary too. People need to be assured that they are being cared for, that there is ongoing assessment of their problems, and that they haven't been forgotten and just left to suffer through the misery of withdrawal. One of the most important aspects of withdrawal management is that it needs to be individualized. We can know what withdrawal looks like from alcohol, from other substances, but each person's experience is going to be different. What they've experienced before, the kinds of problems that they have that can significantly increase the severity of their withdrawal. All of those things need to be taken into consideration, as well as many others. Substance abuse often leads to very significant health issues as well, and we need to be aware that people can be suffering from very chronic illness related to their drug and alcohol use. Things such as liver disease, hepatitis, and other problems with the liver, including late-stage liver disease and cirrhosis of the liver. Also, chronic infections in the body, usually caused by intravenous drug use or by a compromised immune system or by the just lack of good health care throughout the use of drugs and alcohol. Trauma suffered as a result of fights and of accidents and risk-taking and injuries that occurred as a result of behaviors that occurred under the influence of drugs and alcohol. Also, a person's ability to make decisions, to think, to remember, all of those cognitive abilities can be significantly impaired. Psychiatric disorders can be masked or treated sometimes in a self-management kind of basis by a patient who is suffering from anxiety, depression, and other more serious psychiatric disorders by using those substances to medicate their symptoms. So psychiatric disorders can manifest themselves as people stop using drugs of abuse and alcohol, and the underlying problems are then for us to recognize and deal with. Also, nutritional deficiencies are very common. People tend not to eat or eat properly when they're using drugs or alcohol, and many of them cause significant changes in appetite and in the utilization of food that we ingest. And cardiac disease, all kinds of problems with heart function, with hypertension, and with direct damage to the heart as well. Detoxification and withdrawal are stressors as well, and they may increase the symptoms of other medical or psychological problems that people have, and may not be related at all to their alcohol or drug use or have been a causative factor in those particular medical problems or psychological problems. But the fact that they're going through withdrawal can be a very significant impact on symptoms of all kinds of other medical or psychiatric issues. It is very important to note that medications that are used to treat withdrawal must be very carefully monitored and carefully administered during withdrawal to the clients who are in need of medication intervention. Careful monitoring by the staff who is responsible for the care of these patients helps to prevent overdose, accidental overdose, or overdose caused by the fact that the clients are cheeking the medication, saving them all up in an effort to get high on them, rather than having them treat the withdrawal symptoms they're experiencing, or for diversion of those substances where they are holding them or cheeking them and then sharing them with other people around them, with friends and family, with other inmates, to be used in in exchange for other services or other products or whatever in the jail system, and for misuse of them by instead of taking them by mouth and taking them sublingually the way that they're prescribed, they hoard them, misuse them by injecting them or breaking them down and snorting them, or using them in a route that wasn't the intended use of those prescription products. Truly, detoxification or withdrawal management is just the beginning of the treatment of alcohol and drug problems. And if there's resources available, the individuals who are being treated for detoxification should be considered for follow-up and psychological support through group therapy or individual counseling or the 12-step recovery meetings or other similar programs that exist in our cities in our state of North Dakota, and for drug education and for either non-residential or residential drug treatment programs that are available throughout our state as well. But they should not just be treated for the withdrawal and then sent on their way without some additional support and treatment being offered to them. I'd like to expand a bit on some of the principles for care during withdrawal management and how important it is to remember these things in dealing with people who are experiencing these symptoms. Substance use disorders are treatable, and there is hope for recovery. It is seen day in and day out throughout my life and my work in addiction for the more than 45 years now that I've been doing this. I've seen great success in the treatment of addiction. And yet families and friends and sometimes our patients themselves just have no idea that there is treatment available and what they need to do in order to live a life of recovery rather than one of addiction. So we have to be able to understand the process and offer them hope of recovery. Substance use disorders are brain disorders. The more we've learned about addiction, the more we understand the very complex problem this is. And the changes that occur in the brain and in the body as a result of substance use disorders is the basis for the changes that we see in people's behavior and the way they view the outside world. It's not evidence of moral weakness or their unwillingness to change. It is truly a disorder that is likened to other chronic illnesses such as diabetes or heart disease or any of the other afflictions that the human body goes through. Individuals should be treated with respect and with dignity at all times. And sometimes this is very difficult to do, as the effects of drug and alcohol very often cause a loss of self-respect and of self-dignity. And many people act out in ways under the influence of drugs and alcohol and in stressful situations where they're being incarcerated or charged with legal issue, that their behavior is beyond their control, and they act out in ways that is very disrespectful to others and undignified. But it is our purpose to make sure that people are understood for the acting out that they do, that they are safe from harm for themselves and others, that they are treated with that kind of respect and dignity. Individuals should also be treated in a non-judgmental and supportive manner. People did not choose to be drug addicted or alcoholic any more than anybody chooses to be diabetic or choose to have any other kind of chronic illness. It's very difficult not to be judgmental at times and to find it difficult to be supportive because people are acting out in ways that are very difficult to understand and to adapt to. Families have put up with a lot of behaviors over a long period of time, as most of us have if we've been experienced in any way with people under the influence of drugs and alcohol. We find them very difficult to be around and to handle. So a very non-judgmental and supportive approach can be very effective in dealing with people who are feeling out of control of the situation themselves. Individuals should also be treated with due consideration for their individual backgrounds, their cultural differences, their preferences, their sexual orientation, disabilities they may have, vulnerabilities, which might be of a hidden nature and not always seen when people have a very tough exterior. And also, we need to remember that people have great strength. And I think we forget that sometimes when we're dealing with people with addiction issues, is that they are survivors. They've gone through things that many of us would never have even the vaguest notion of understanding. But when you think about the strengths and the resiliency of people with this illness, it helps you to realize that with some help and support, that they can turn this around and be able to live a life differently than what they've been experiencing. The American Society of Addiction Medicine has developed criteria that will help us to understand withdrawal management. There are different levels of care and different types of service delivery of these services, and the kinds of support systems and staff and therapies and assessment and the treatment plan review, the documentation standards, as well as the discharge criteria have all been very carefully written and discussed and calculated by the American Society of Addiction Medicine. These are used throughout our country to help people understand withdrawal as well as other levels of treatment services to be provided to people with substance use disorders. And according to the information contained on the slide here, see that in the different levels of care from 1 through 4, there are a lot of different approaches and ways to deal with withdrawal management. People can actually be treated in their homes or through their physician's offices. They may not even need extended monitoring, but can be given medications and support and information about withdrawal and be able to be safely managed at home with the support of other people in their home. And also then referred to ongoing, maybe outpatient treatment services that will help them to understand their illness and to stop drinking or stop using the drugs of abuse. Level 2 withdrawal management is also ambulatory, but may require an extended kind of on-site monitoring. These clients may still live at home, but they come in for day hospital service and they have longer hours and observations ongoing with the staff who are providing withdrawal management. Level 3.2 is clinically managed residential withdrawal management, such as in a social setting, a withdrawal management program that is carefully monitored, and patients may be on medication. They are closely managed under those residential systems rather than on an outpatient basis. Level 3.7 is medically monitored inpatient withdrawal management that can be done either at likely at a freestanding withdrawal management center or used to be described as detoxification or a detox program. But these are medically monitored patients who have a required ongoing medical attention on an inpatient basis to safely withdraw them from the drugs and alcohol. And level 4 withdrawal management is medically managed intensive care withdrawal management. This is in an acute care facility or in a psychiatric hospital inpatient unit where someone requires interventions on a medical basis to save their lives. These are people who are suffering the worst of the withdrawal symptoms and need the most intensive care. It is really important to know what community resources are available for withdrawal management where you live and do your work. What are the current procedures that you have in your facility for management of withdrawal of the people that you're seeing, of the inmates or the newly charged clients that you are seeing in your facilities, and what do you do currently when you have concerns about somebody who may be either under the influence of drugs or alcohol or that you might be concerned about for possible withdrawal. And you also should identify what medical and psychiatric resources are available in your community and where you refer people for these sorts of problems in your community. In the clinical assessment of patients who may require withdrawal management, some of the assessments that we would want to take into consideration are the patterns of substance use. In the interaction that we have with people when they're first admitted to a facility for withdrawal management, we want to ask some very specific questions about their patterns of use. They may or may not be forthcoming with this information, however, unless they're very concerned about withdrawal themselves. But generally, people extremely minimize how much they've been using or are afraid to tell it because of possible retaliation or charges against them. But for the interaction that takes place to talk about medical and mental health needs in an assessment of this nature requires a development of a rapport first with that person so that they will feel free to talk about what their use has been like, so we can help predict what kind of symptoms they might be experiencing and try to help them through that. Previous withdrawal management that they've gone through is also an important consideration. We'd want them to talk about previous hospitalizations or treatment or what they've gone through in the past with withdrawal, because that can sometimes be a very good assessment tool to use to determine what we might be dealing with in the current withdrawal management issues for that person. A general physical assessment is generally done where we look at all their vital signs, temperature, pulse, blood pressure. Hopefully we'll be able to do a urine drug screen or a toxicology screen to determine what level of drugs are in their system and what they've ingested before coming into incarceration. And also we want to look for any physical or sensory or cognitive disabilities that a person might be dealing with. That can certainly impact the way we interact and the way we can communicate with someone who is in acute withdrawal. If they have deficits in these areas, it makes it sometimes even more difficult to discuss the possibility of withdrawal or to even explain to people what they're going through as far as the process their body takes in withdrawal. We also want to look at their current mental status, determine whether or not they're feeling depressed or anxious, and also look at their current suicide risk to determine whether or not they present a current risk, if they're having ideation, if they have a specific plan in mind, if they've ever made previous attempts, and also look at their history of violence and whether or not we can expect that as part of the withdrawal process with these patients. Signs and symptoms of conditions that would require immediate medical attention include some of these, and there may be other circumstances too that you become very concerned about, but symptoms such as the ones we're going to discuss here should raise your concern enough that you would seek immediate medical attention for anybody with these particular problems. Any change that you see in a person's mental status, somebody who goes from being alert and speaking with you to someone who is unresponsive and or not in touch with reality, but a significant change that you see from one time of assessment to the next should require immediate medical attention. Increasing anxiety to the point where people are unable to respond to support or to encouragement, and they become very panicky and unable to be talked into relaxation or being able to deal with that anxiety. People who are experiencing hallucinations can sometimes be, not much of a threat, but and their hallucinations are not to the point where they are acting out towards others or towards themselves with them, but in other cases, and it's very hard to predict how this is going to go or how it's going to happen, people are experiencing visual, auditory, or tactile type of hallucinations. They can become very, very disturbed and act out against themselves or against other people because they are out of touch with reality about what's going on around them. Temperature that is greater than 100.4 degrees. These patients should be considered to be potentially infectious. An increase of temperature in our body generally means it's fighting off some sort of infectious process or dehydration or other significant problems. So if their temperature is elevated, make sure that they are safe in their current situation, and you're protecting the safety of your staff and other people who may be in the vicinity with them. they should be assessed. Significant increases or decreases in blood pressure and heart rate. Any change that you see that is significantly beyond what's considered within the normal ranges for blood pressure and pulse should be assessed by a medical team. Patients who are unable to sleep, who are, it's not just that they have a mild insomnia or they're anxious or they're having difficulty falling asleep because they're in jail for the first time and that sort of thing, but people who have insomnia where they cannot close their eyes, they're extremely agitated, and they may be sleep deprived over a long period of time, especially with the stimulant drugs like methamphetamine, and a state of insomnia sometimes can bring about other problems such as hallucinations and acting out. Any abdominal or chest pain that you are unable to assess, any complaint that a patient has of symptoms of that nature are, something that needs to be examined by a medical team, not something that in the sense of withdrawal management in a jail setting can be monitored or determined if it's of significance or not. Let a medical team decide that. Any episodes of bleeding, upper or lower gastrointestinal bleeding, so vomiting blood or any bleeding from the rectum or blood from any orifice needs to be assessed. Any change in responsiveness of the pupils, if you're monitoring pupil changes where people may have very large pupils that are very dilated or pupils that are very pinpointed, changes in responsiveness to that if they remain kind of extremely dilated or extremely pinpoint, or if one pupil is significantly larger or smaller than the other, and this is new to the person that you are assessing, that needs to be immediate. It could be internal damage to the head or to the brain, and those are the kind of symptoms that you'd want to be very responsive to. And reflexes for people who are, who assess those in the sense of a medical detox, any heightened reflexes can mean significant problems as well. Not something that's generally checked in a jail system or that is easily assessed by non-medical personnel, but any of these other signs or symptoms that you become concerned with, just refer that person to have an immediate medical assessment. There is never an error in asking for help if you have a concern about somebody, and sometimes it's just a feeling that you have, and you just know something is not right, and you don't have to define it or diagnose it, you just have to refer it and take some action to make sure that person is going to be okay. Patients with mental health needs that require immediate attention certainly would include anybody with suicidality. So anybody who is coming into withdrawal management or detoxification services should be evaluated for suicide risk. And during acute intoxication and withdrawal, it's very important to provide an environment that minimizes the opportunity for suicide attempts. So look at the environment that your person is in, and to make sure that there are safe areas for people to be who are experiencing withdrawal symptoms and may develop despondency or suicidal ideation. Frequent safety checks should be implemented, and certainly there are policies and procedures available in every jail setting in the state of North Dakota that speaks to this. So we should follow your facility policies and procedures in this regard. Patients at risk for suicide should be placed in areas that are very closely monitored by staff and referred for mental health services as needed. People who are very angry and aggressive because they are under the influence of drugs or alcohol, and truly all patients have that potential who are intoxicated, but if they have a history of significant violence, that is something certainly to be taken into consideration. Symptoms associated with increased risk of violence includes sometimes hallucinations where people are unaware of what's really going on around them, and paranoia or fear or significant anxiety of what's going on in their environment or what's happened to bring them into incarceration, and depression at the thought of having to deal with these issues or deal with family in regards to these issues, or the society at large and the people that they work with, that they live nearby. All of those things can cause an increase in anxiety and depression and suicidal ideation. Certainly physical restraint should be used as its last resort, but that it is available for use for people who are at harm, can present a risk of harm to themselves or to others. There are some issues that people may present that can significantly increase the risk of withdrawal. People with a history of brain injury, whether it was in the past or current, may have more significant symptoms, more management problems in their withdrawal from drugs and alcohol. People who have a history of a seizure disorder, that may not be directly related to drug or alcohol use, but have a history of seizure disorder as a result of previous head injury, or just a organic kind of reason for a seizure disorder. People with a history of cardiac disease or liver or kidney disease can also have an increase in the risk of significant withdrawal and the morbidity that can occur as a result of alcohol or drug withdrawal, based on other problems in their body where they're having difficulty with responding appropriately to withdrawal management. People with significant psychiatric disorder or who have an advanced age, and we see more and more of that in the boomer population as they age, and there's many more of us in that age group that have a history of drug and alcohol use. And with any advanced age, even over the age of 55, withdrawal becomes significantly more severe and presents more of a withdrawal management challenge. And of course, women who are pregnant present significant risk as well, not just to their health, but to the health of their unborn. And people with a risk of suicide who have a significant history of suicide attempt or possible suicidality present a significant risk in withdrawal as well. In order to safely manage withdrawal for people, it is really important that we learn how to engage them in their own process of recovery, and how we as professionals can help in the process by engaging them and helping them understand what they're going through. So educating the person on the withdrawal process is very important and vital in bringing them along in this process of withdrawal and helping them to understand that it is an acute problem. It won't last forever. It does get better with time, with treatment, and can be successfully managed. The use of support systems is really important. And in many of our jail settings, there's a lot of people who provide support. The nursing staff, there can be clergy that can provide support. Sometimes there are people in the community, in the 12-step community, who do visits at jails. It could be a great support to the staff there to utilize people who have an understanding and compassion for people who are incarcerated and who are drug and alcohol dependent and involved in withdrawal management. To utilize those support systems is a precious commodity. It's also very important that we maintain a drug-free environment in a withdrawal management program, which means that doesn't mean that we don't provide medication assisted therapies to people, but that we have drug-free environment free of other drugs that are not prescribed appropriately, that are illicit in nature, that people may smuggle in or may misuse medications that are prescribed for them and share them with others in the facility that they're in. So maintaining a drug-free environment is very important. Considering alternative approaches and a motivational enhancement to help people to understand where they're coming from. Sometimes a very direct approach or confrontational approach to people who are experiencing these kinds of symptoms are very detrimental actually to the process. So seeking to find out where that person is at in their in their belief and their understanding and supportive approach to them, and gently moving them in the direction of seeking help or seeking recovery can provide us with much better responses to people who are experiencing these very frightening kinds of symptoms in this process of withdrawal. And fostering a therapeutic alliance with that person is by engaging with them in a way that they are a part of the decision making for themselves. That is a very important thing, that you can provide information to them, you can do the education, you can know what might have worked for other people, but unless you have an engagement, unless you have an alliance with that person, and they begin to trust you and understand that you're there to help them, it makes it very difficult to move a person along towards the right path. The withdrawal tools, assessment instruments that we are going to talk about in this segment were designed to be utilized by non-medical people to look at the withdrawal symptoms and the severity of the symptoms, to be able to assess them, to put a number to them, then to be able to communicate that information to others working on the same team or to a medical team that you are referring a patient to for further assessment. The CWAR, the Clinical Institute of Withdrawal Scale for alcohol, or the CIWA-AR, the AR is alcohol revised, was developed in the provinces of Canada to assess people for alcohol withdrawal. It has been utilized across the United States and across Canada for a number of years now. It is standardized, and it is very simple to learn to use and to determine then the severity and the nature of the withdrawal symptoms that people are experiencing. The CWA-B is an adaptation of that initial, and CWA for alcohol that looks at specifics for benzodiazepine withdrawal that we'll discuss as we go along. The COWS is the Clinical Opiate Withdrawal Scale for use of people experiencing withdrawal from the opiate drugs, the prescription narcotics, and from heroin. Other alcohol and drug testing options that can help determine where someone is at as far as the withdrawal they're experiencing and what we might expect with them are laboratory tests, urine drug screening, and a breathalyzer, which gives us an idea of the amount of alcohol currently in that person's body. The specific withdrawal management that we're going to discuss is in regards to alcohol, benzodiazepines or tranquilizers, barbiturates, which were generally utilized for the treatment of sleep problems, opiates, cocaine, methamphetamine, and other stimulants, and then inhalants. The next two slides look at the percentages of alcohol in the human body and the impact that it has on physical symptoms and behavior. There is a great variety in how people respond to alcohol. And the longer people drink and the more significant their dependence on alcohol becomes, the higher their tolerance generally is, which means they can drink lots more alcohol and not have the same kinds of symptoms of intoxication that you'd see in a novice drinker. So as people develop problems with dependence, they experience this tolerance, and you may see very high levels of alcohol in their system without the anticipated kind of symptoms of intoxication that you might see in a novice drinker. So generally, the lower the level of alcohol, the less kind of behavior changes or physical changes that you see, and the greater risk comes in larger amounts of alcohol, to the point that people overdose and die as a result of the amount of alcohol in their system. And whether someone is a novice drinker or a long-term drinker, the lethal doses of alcohol can kill anybody. It's not just the novice drinkers who suffer those overdoses, but oftentimes it is the veteran drinker as well. But mild symptoms of mood and behavior changes usually occur when the blood alcohol is between would be 0.02% and 0.1% alcohol. There's reduced coordination. There's impairment of ability to drive a car, operate machinery. So this is why at 0.08 across the United States, that is the level of intoxication where people can be charged with driving under the influence. And it does impair our ability to respond to machinery or operating a car appropriately. So that has been throughout the United States now the standard of intoxication. Blood alcohol levels of 0.10 to 2.0. We also see reduced coordination, speech impairment, trouble walking, general impairment of thinking and judgment, sometimes even combative or psychotic kinds of behavior in some people. And as the level starts to rise into the 0.20, 0.3, range, you see marked impairment of people's ability to think or their coordination, a reduction of their level of alertness, and sometimes they're experiencing memory blackouts at this time where they are not even able to remember what's going on, what they've said, what they've done, where they've been, what they're involved in. And there may be nausea and vomiting at this point where we have that little trigger in our brain that says when you've had too much alcohol in your system, it tells you to vomit to get rid of it. And that often is a downfall for people who are experiencing these high levels of intoxication, and that's generally what is the cause of death, that people are nauseated, they vomit, they aspirate or suck that vomit back into their lungs, and they die as a result of choking to death on their own vomit. Great care needs to be taken with people who reach levels in this slide of 0.3 and 4 up to 0.8%. There is significant expectation of death as a result of this high level of alcohol. The body just does not tolerate these levels of alcohol in a novice user, and even in someone who is a very significant user of alcohol, the body just reaches a point where it can't manage this amount of alcohol in the system, and the cause of death then is related to serious decreases in pulse and temperature and blood pressure and rate of breathing, and death occurs as a result of that if the person has not choked on their own vomit. Generally, people are incontinent of urine and bowel. That can actually occur at any level of intoxication. The higher the levels, of course, so the less control you have over your body functions, and you'd see that in those high levels of alcohol. But significant for these levels is all of the impact that it has on the vital functions in the body. And patients with levels this high need to be seen by a medical team. They can't be safely managed in a jail detoxification management that they need medical intervention. Individuals who present intoxicated at any point should be presumed to have an alcohol use disorder unless you prove it otherwise. That you just assume then that people that are coming in under the influence have an alcohol problem, so that you can appropriately assess them, anticipate withdrawal, and treat it as appropriately as you can. The symptoms of acute alcohol withdrawal can generally start within 6 to 24 hours after a person has had their last drink, and even when there is still significant blood alcohol concentrations in that person's body. Uncomplicated alcohol withdrawal is usually completed within 5 days or less, but the signs and symptoms are highly variable and very difficult to predict, but these are some of the things that you look for. And in the CWA, or the alcohol scale, it will address all of these issues. Restlessness and irritability, anxiety and agitation, all of those are very, very common in people who are in withdrawal, especially people who have experienced it before and know what's coming. They can be highly anxious about having gone through it before and maybe having had significant symptoms and are very worried about what they're experiencing. Anorexia or loss of appetite, nausea, and vomiting are very, very common in withdrawal. Tremor of the hands, and we assess those by looking at the extended arms of a person who is experiencing withdrawal to really assess how significant the tremor is, but also elevated heart rate and increased blood pressure. Sometimes very high blood pressures are recorded and very high heart rates for people who are in acute withdrawal. Insomnia or inability to sleep, or when they are sleeping, they have intense dreaming, generally of very disturbing nature or significant nightmares as a result of usually ongoing sleep deprivation under the influence of alcohol. Generally, people have very poor concentration, have impaired memory and judgment. They have an increased sensitivity to sound, to light, and to tactile sensations or things touching them. It is very important to know that they are easily startled by sound. Better to keep the area that they're in as quiet as possible, lower the lights, but not have shadowy areas in the situation that they're in the facility that they're in. Also, people may experience all types of hallucinations that might be mild to very severe and completely out of touch with reality. And they can be auditory, or things that they're hearing, or things that they're seeing, or things that they feel are on their body, bugs walking on their body, feeling the variety and the different types of hallucinations that people experience are as individual as each person is. And some are very frightening, some are not so frightening to people, and they will talk with you about them. They can be presented with reality. They have some idea that what is going on around them isn't really happening and can be brought back to reality. But for many people, as they progress in hallucinatory experiences, they can't be presented with reality. They are unable to tell what's real and what's not. Delusions can also occur in alcohol withdrawal. Usually they're very paranoid in their beliefs, or feel they're being persecuted, are afraid of being attacked, afraid of other people's possible treatment of them. So they can be very, very difficult to deal with because they are so frightened. People may also experience grand mal seizures, which is a significant seizure where there's a loss of consciousness, the clonic and tonic movements in the body where they get very stiff, and then they have very jerking movements, sometimes incontinent of their urine, sometimes incontinent of their bowel as well, and have been very, people who witness them are very frightened. They're a very frightening experience, and it is a likelihood for people who have experienced seizure before that the next time that they go through withdrawal, they can expect to have seizures as well. And it tends to grow and progress as the illness of alcoholism progresses. Sometimes they have higher temperatures than normal, but as we talked about earlier, if their temperature is above 100.4, they should be assessed for possible infections. And delirium and disorientation with regard to time, to place, to the person they're talking with, to the situation they're in, and a fluctuating level of consciousness where they're with you and then they're not, where they're arousable and other times when they're not. So all of those things can occur with acute alcohol withdrawal. In order to determine if someone is in need of medical management of their alcohol withdrawal symptoms, deciding whether or not to use medical management requires that we separate people into three groups. The first group is a patient with a history of the most extreme forms of withdrawal. That is, they've experienced seizures and or delirium. Medical treatment of this group of people should be proceeded with as quickly as possible due to the kindling phenomenon, which I discussed earlier, where people who have a history of withdrawal are likely to get more and more severe with each attempt that they have at stopping drinking. And that kindling effect means that they start where they left off and continue to be more and more significantly impacted by withdrawal. In the second group, patients who are already in withdrawal and are demonstrating moderate symptoms of withdrawal also require immediate medication and medical attention. And in the third group, patients who may still be intoxicated or have been abstinent for only a few hours but haven't developed any signs or symptoms of withdrawal as yet. A decision could be then made with these patients to either periodically reevaluate them and determine if they're in need of care, or may look at some of the other factors. If they're in an advancing age, the number of years that they've been alcohol dependent and the number of previous treatments they've had, or previous either treated or untreated severe withdrawal. There's an opportunity then to decide whether to treat them immediately or to just evaluate them over a period of 6 to 8 hours and then determine whether they're in need of symptoms or their symptoms rather are in need of medical attention. Medications that are commonly used to treat alcohol withdrawal are the benzodiazepines, which are alprazolam or Xanax, lorazepam or Ativan. Sometimes the longer-acting benzodiazepines like Valium or Librium are also used to treat alcohol withdrawal. The benzodiazepines act on the same receptor sites in the brain that alcohol does, and given in doses over a period of time, people can generally be detoxified from alcohol. The danger is with benzodiazepines is they can be highly abused as well, and the nature of those medications is that they present a very supportive and safe withdrawal from alcohol, but need to be utilized only in the short term because with longer term use, people with a history of alcohol can very easily have a transference of their dependence to drugs in this category. Generally, benzodiazepines can be given in a lot of different ways, and everybody that prescribes these medications seems to develop a management style that they're most comfortable with. There is, opportunity to really significantly individualize how medications are used to treat alcohol withdrawal. So it is dependent on the prescriber. Sometimes benzos are given in a loading dose when we know that there is the potential for withdrawal and a history of that a large dose of the benzodiazepines is given to ward off the worst of those symptoms. And then the assessment factors that we use to determine people's response to the medication with the CWA is assessed and determined then, triggered by the symptoms that the person is experiencing. So if someone becomes very tremorous or very nauseated or vomiting, or if they have significant changes in their sensorium or what's going on, their awareness of what's going on around them, those kinds of symptoms may trigger a dose of medication. So the people who are assessing them would determine what their symptoms are and then give them medication dependent on their current symptoms and the severity of them. Sometimes benzodiazepines are given in gradual tapering doses, where you start out at a higher level and then taper the dose down over a period of several days. That seems to work really well in a great number of people, to start out with more and then gradually taper it and ease people off that way. And sometimes a single daily dosing protocol is utilized for people where they get a dose of medication of usually the longer term medications once a day, and then are dosed depending on the length of their withdrawal symptoms. Other medications used sometimes for the treatment of alcohol withdrawal are barbiturates for people with a history of seizure disorder or seizures. Sometimes barbiturates such as phenobarbital are used in a tapering dose as well to ward off possible seizures with alcohol withdrawal. Barbiturates are very carefully prescribed and utilized in this population, and over usually just a very short period of time to get people safely off of alcohol. Anticonvulsants such as Dilantin or Tegretol are often given to people who have a history of seizure or the potential for that. Beta blockers such as clonidine, which is a blood pressure treatment medication, which is used for treatment of alcohol withdrawal, as well as other withdrawal, as we'll talk about in slides to come. But clonidine is also besides reducing the blood pressure readings, can also reduce the amount of anxiety people are experiencing, and it is a very effective medication in treating alcohol withdrawal. Sometimes antipsychotic medications such as Haldol are used as well for people who are experiencing hallucinations and loss of touch with reality or delusions. Sometimes relapse prevention agents are used too once people have achieved sobriety. Medications such as Antabuse, which is a medication taken by mouth on a daily basis that does nothing in the human body except to react to alcohol if somebody takes a drink with it. So Antabuse is a deterrent in that people realize if they drink with it, they would get very severely ill with a combination of Antabuse and alcohol. So it is sometimes used on a daily basis for people to make a commitment to sobriety when they've been very impulsive in their drinking or have a very difficult time stopping initially. Sometimes Antabuse can be a very positive support medication. And naloxone, which is used for a number of other treatments of drug and alcohol problems, is specifically used as a relapse prevention agent with alcohol for people who have been absent for a period of time. Start taking naloxone orally in the form of Trexan, which is the pharmaceutical name of it. They take it by mouth every day. It reduces their craving for alcohol, and if they do drink, it minimizes the effects that alcohol has in their system, and generally will stop drinking much earlier than they used to. Now, naloxone is also available in an injectable form on a monthly basis called Vivitrol, which given on in a large dose once a month reduces craving and the effect that alcohol has if someone does drink while they have that naloxone in their system. The major goal of medical detoxification is to avoid seizures in a special state of delirium called DTs, or delirium tremens, and that is done with the aggressive use of a primary detoxification drug, either the benzodiazepines or barbiturates as I described. Death and disability may result from DTs or seizures without medical care. For patients with a history of DTs or seizures, early benzodiazepine treatment is indicated as soon as possible. And patients with severe withdrawal symptoms or multiple past detoxifications, such as more than 3, or a co-occurring very unstable medical or psychiatric condition, should be managed similarly. They should be treated immediately. Two special syndromes related to alcohol use, chronic alcohol use, are Wernicke's and Korsakoff syndrome. Wernicke's encephalopathy is a neurological disorder that causes a change in muscle coordination as well as mental confusion and weakness. Korsakoff psychosis is a chronic neurological problem which includes both past memory and current memory and has a profound deficit in a person's ability to do new learning as well as remote memory. Generally, patients with Korsakoff psychosis confabulate things or make up stories in order to cover the gaps in their memory. Both of those syndromes are related to thiamine deficiency, which is caused by chronic use of alcohol. Sometimes the replacement of thiamine in the body can reduce some of the symptoms of Wernicke's or Korsakoff syndromes and have a return of function for some people, but for others it can become a chronic problem even in periods of sobriety. The CWA scores in the assessment tool we talked about earlier are represented here in this graph, in this slide. CWA assessments are easy to learn, easy to teach, and are available with the links that I've provided at the end of these slides. but they should be done at regular intervals to assess for changes in physical and mental status. The table looks at the score of the CWA, the level of withdrawal that is represented by those numbers, and what the recommended treatment is. Generally, a score of less than 10 are signs of mild withdrawal, and generally supportive non-pharmacological therapy can be utilized along with close monitoring of that patient in reducing the withdrawal symptoms without some sort of medical intervention. Of course, if a person has a history of alcohol withdrawal seizures or comorbid cardiovascular problems, you would want to have immediate medical attention for those things. In the 10 to 15 range, this is considered moderate withdrawal, and medications are usually indicated to reduce the symptoms and to reduce the risk of major complications of withdrawal from alcohol. Anything greater than 15 is considered a severe level of withdrawal, and a very strong consideration should be given to hospitalizing those inmates who exhibit severe symptoms, as they develop an increased risk for severe complications as a result of withdrawal. So these standards are available in the documents described at the end of these slides, and additional information in regards to the use of the CWA and its regular assessment use is also included in that information. Benzodiazepine withdrawal is very similar to alcohol withdrawal, and often use of benzodiazepines concurrently with alcohol complicates the withdrawal management. The CWA-B for benzodiazepine is the assessment tool that's used to assess those symptoms of benzo withdrawal, which are a little bit different than the assessment for the alcohol withdrawal using the standard CWA-AR. Though that information is also included in the links at the end of this slide presentation. But in benzodiazepine withdrawal, generally the longer acting benzodiazepines are used on a tapering schedule to get people safely off of benzodiazepines, and usually it takes significantly longer to safely manage withdrawal from benzodiazepines. So the longer acting medications in the benzodiazepine category, clonazepam or Librium or Valium, are often utilized for those very rapidly used benzodiazepines, Xanax, and Ativan. So also utilized in the treatment of benzodiazepine withdrawal are beta blockers such as propranolol or clonidine, which reduces blood pressure, which also reduces anxiety and some of the symptoms of withdrawal. And generally, anti-seizure medications are not utilized. It's not as common to see seizure activity in benzodiazepine withdrawal, not as common as it is with alcohol withdrawal. Generally, in the early stages of withdrawal, the symptoms are an increase in pulse and blood pressure, anxiety, panic attacks, restlessness, and gastrointestinal upset such as diarrhea, nausea, and vomiting. And in the mid stages of withdrawal, those symptoms progress to be more and more severe and may include diaphoresis or heavy sweating, insomnia, inability to sleep or eat, and diarrhea. In the late stages, people may develop delirium and hallucinations and changes in their consciousness. Profound agitation and seizures and death have also occurred as a result of benzodiazepine withdrawal. So people showing signs of late withdrawal definitely need to be hospitalized. Sometimes people can be utilized in a tapering dose of benzodiazepines over a period of time under the supervision of a medical team, but may not need to be directly hospitalized. The barbiturate drugs, which are not as commonly used as they used to be, include things like Seconal, Tuinol, Nembutal, phenobarbital. All of the drugs in this category have a very similar withdrawal that we've discussed previously to alcohol alcohol and benzodiazepines. Symptoms generally develop within just a few hours after the last dose, but there is a significant concern with respiratory depression or changes in breathing as a major consideration with barbiturates, because it has a very direct effect on the breathing centers in our brain. So the result of a combination of barbiturates and alcohol has been the cause of death with many people in the past, when barbiturates were much more commonly prescribed to treat sleep disorders. But early symptoms of withdrawal can also be an increased pulse and blood pressure, anxiety and panic attacks, and restlessness, and that same GI distress of nausea and vomiting and diarrhea. Mid-withdrawal, those symptoms increased to be more and more significant, and late withdrawal also involves changes in consciousness and profound agitation and hallucinations at times, instability and seizures, and any of those kinds of late signs of withdrawal or signs and symptoms of those withdrawals should be promptly hospitalized. Treatment is usually a stabilization of phenobarbital followed by a tapering schedule. So phenobarbital is again used to get people off of barbiturates in a tapering schedule over a period of time to bring them safely off the medication. As we begin our discussion about the opiate problem in our state and in our nation, it is important to note that the increased use of these opiate drugs has caused a significant impact on all people dealing with this crisis. And that can be our medical community, our law enforcement, our emergency response teams, families, schools, churches. Almost everybody has been impacted by this, and everybody has a story to tell about the impact that this opiate crisis has had on their lives. Rarely do you talk with anybody who hasn't been impacted in some way, who knows someone who's died of an overdose, who has had significant problems as a result of opiate use. So there's many reasons for this continued problem in our nation and the crisis that we're experiencing in our state with the loss of people due to this drug. What's different about it compared to alcohol and other drugs of abuse is its danger, its potential for death as a result of overdose from this drug. So it has left us with a particular impact and reason for us to be together, to be talking about this, for us to, as communities, address the issues and learn to deal with this particular problem. There's lots of forces at work to do this, and my purpose is to talk about what intoxication looks like, what treatment of an opiate overdose looks like, and how people might be successfully treated for withdrawal management of opiates. The signs and symptoms of opiate intoxication include slowing of all of the functions of the body. If you think about opioid intoxication, that's what you should think of: slow and low. Slow pulse, low blood pressure, low body temperatures, a sedation or a look of sedation in people who are under the influence of opiates. Pinpoint pupils, the pupil, the black part of the eye, that's generally pinpoint under the influence of the drug. Slowed movements, slurred speech, head nodding or nodding off, or people look like they're falling asleep. Sometimes there is a sense of euphoria that's not easily described to others, but that is the nature of the way this drug brings people back to it all the time, is that internal kind of sense of euphoria that occurs under the influence. It has pain-killing effects, which is what it's usually prescribed for the treatment of pain, but for the people who become dependent on it, it isn't for the pain that is often used, but for the other euphoric effects of it. And a calmness that kind of takes over or a sense of that for people who are under the influence of opiates. Signs of opiate overdose progress from the description of what intoxication looks like. Generally, the face of a person who is overdosed is extremely pale and or clammy to touch. The body is very limp. The fingernails or lips have a blue or purple color to them. Vomiting or gurgling noises may be heard in a person who is overdosed, who might have aspirated their vomit when they've vomited under the influence of the opiate. They cannot be awakened from sleep, and they are unable to speak. Their breathing is very slow or stopped. Very slow, meaning maybe 1 or 2 times a minute that they are taking a breath. And the heartbeat is very slow and sometimes very difficult to find, or it has stopped. So a person who is overdosed may stop breathing, their heartbeat stops, and as you know, those are very vital things to keep us alive. So those are the signs of overdose, and death would result without treatment. There's a drug that's available that can be administered to reverse the effects of opiates. Narcan or naloxone does nothing else in the human body but that. It doesn't have any unusual side effects, or it isn't used for treatment of anything else. The only use for Narcan or naloxone is to be administered, is to reverse the effects of opioids. So this is what will save lives. This is what is the most important management tool that we have right now for opioid overdose. Narcan is available in nasal applicators or in injectable form that is given intramuscularly into the body. The nasal applicator can be used to just squirt the drug into the nares and is available and can be prescribed by a participating pharmacist as well as an MD, a doctor, or a nurse practitioner, or a physician assistant. So anybody who is seeking to have Narcan in their possession can do so by applying through a pharmacist or through any of those other providers. Narcan can be administered safely by those who have been instructed on its use, and it can save lives. So it is commonly carried now by police officers, by first responders, by family members who are living with an opiate user and have witnessed other overdose episodes. It can be purchased by someone who is an opiate user themselves to treat possible overdose. There is a move in some quarters where Narcan would be prescribed along with a prescription of opiates to anybody who's prescribed opiates for the treatment of pain, so that it would be on hand for accidental overdose for someone else in the household, or for someone who might have taken an opiate, forgot that they took it, take another dose, be sedated and not remember if they took it or not, take another dose, and end up accidentally overdosing on their own prescribed medication. So administration may need to be repeated for the longer acting opiates like fentanyl, which is a very powerful opiate and available on the street and misused on the street. And there are newer forms of fentanyl available called carfentanil or furfentanil that are very, very lethal. Even in very small doses can cause overdose. And even people exposed to them, like law enforcement or first responders or environmental cleanup crews or whomever that are exposed to that level of drug, even in air particles, when it's released into the air, can be subject to overdose, even in very small, minute amounts of the drug. So all the DEA agents have been trained to utilize it and carry it for treatment of overdose of their own people or themselves in situations like that, or in their drug sniffing dogs who are at risk for overdose as well. So the nasal product is inserted into the nose, sprayed there, and sometimes with those heavier types of opiates, as I said, the administration of the longer acting opiate for those longer acting opiates may need to be repeated multiple times in order to bring someone back. The idea with having Narcan available is that you call 911 for assistance and administer the Narcan, and then wait for help to arrive to reverse an overdose. People who have overdosed, if they come out of the overdose, they are generally kind of combative, angry about being pulled out of that. Whether it was an accidental or a planned overdose, they don't feel well coming out. The Narcan kicks the opiates off the receptor site and causes significant withdrawal symptoms as soon as the person comes back to consciousness. So not always are you considered the hero for that person, but it is important to save a life in order to be able to address the issues of addiction in other ways. The symptoms of opioid withdrawal are the exact opposite of what you see with somebody who is intoxicated. So you think fast then with opiate withdrawal: fast pulse, high blood pressure, high body temperatures, insomnia or an inability to sleep. Very enlarged pupils are seen in withdrawal. Abnormally heightened reflexes, sweating, goose flesh or goosebumps that alternate with feeling very, very cold and cold to the bone to feeling very hot and flushed and sweaty, an increase in respiratory rate, tearing in everything that runs in the human body will do so in opiate withdrawal. Tearing, their nose runs, they have severe diarrhea as a result of withdrawal. Generally, people yawn very, very frequently in the early stages of withdrawal. They may have muscle spasms in any of the muscles groups in their body, abdominal cramps, nausea and vomiting, bone and muscle pain, and a very significant increase in anxiety. So that is the misery of opiate withdrawal, and it can occur very quickly after the last dose of opiates, and generally people who are regular users of opiates have to take more and more of the drug in order to ward off these symptoms of withdrawal. And when they stop using or go without for a period of time, it becomes very uncomfortable for them to be without the drug in their system for any length of time. It is generally said of opiate withdrawal that it's not life-threatening, not medically. However, people who experience withdrawal feel as if they're dying. And rather than wait for the cessation of the symptoms, which can take weeks sometimes for them to dissipate, most prefer to end the torment by using again, and that is life-threatening. And generally, people who've gone through a period of not using will tend to use where they left off with the same amounts that they left off with, not realizing that their tolerance has decreased over a period of time if they're not using. Will start where they left off with the dosage and end up overdosing and dying. And that's what's happened very commonly with people with these particular types of drugs. The COWS, or the Clinical Opiate Withdrawal Scale Assessment, is used to determine the severity of symptoms with the opiate withdrawal patient. Mild symptoms can be in a range from 5 to 12 points, moderate from 13 to 24, moderately severe from 25 to 36, and severe greater than 36. Medication management of opiate withdrawal is most commonly achieved with the use of a number of medications. Clonidine has been around for a long, long time and utilized for the treatment of opiate withdrawal in the forms of pills or patches on the skin that are usually used for up to 10 days of treatment. Clonidine is usually given in doses over a period of time, which reduces the amount of withdrawal that people have by about half. It doesn't do anything for the considerable amount of craving for the drug or physical symptoms that they're experiencing, but it does make it more tolerable. And generally, the clonidine is given over that period of 10 days to 14 days and reduces the withdrawal somewhat. Methadone is a medication that's been used to treat opiate dependence for a very long time in our country, but more recently in the state of North Dakota, have we had the opportunity now to have 3 treatment programs or opiate treatment programs that can utilize methadone to treat opiate dependence. There's one in Minot. Community Medical Services has that program, and the one in Fargo, and there is one in Bismarck at the Heartview Foundation. Methadone is carefully regulated by the Drug Enforcement Agency, the DEA, and in order to develop an opiate treatment program, there are very, very specific guidelines for the use of medication. The dosage of methadone depends on the individual symptoms, and ongoing adjustments are made through the opiate treatment program. Patients generally come daily to the program site. They're given a daily dose of methadone, which is a long-acting narcotic, 24 hours to up to 36 hours in duration, lasts in the body. It's given in a liquid form under close observation, so there's less of a opportunity for misuse of it or diversion to anyone else. Methadone then is adjusted over time. The people in the opiate treatment program see counselors, are in treatment services. They see a nurse who provides the medication, assessment, physicians who prescribe the medication, and they are carefully monitored over a period of time. For some people, it is a shorter term use of methadone to treat the withdrawal and to manage withdrawal. For other people, it is a long-term utilization of methadone in order to live a life that's free of the craving and the lifestyle that goes along with illicit drug use. Methadone is very effective. It's inexpensive and can be carefully monitored with very positive results. Methadone is, after a period of several months, people who are on methadone can be given take-home doses, and they don't have to come to the clinic each day in order to get their dose of methadone. But that is carefully monitored and assessed and regulated by the DEA. Buprenorphine is a medication that can be prescribed by a physician or a nurse practitioner or a physician assistant who's taken a very specific course in its use and the use of the medication in treatment of opiate dependence, but it can be prescribed in a physician's office or in connection with a treatment program as well. Buprenorphine is available in tablets, in patches that are attached to the skin, in implants that go into the skin of the arm. Prescriptions can be on a short-term basis to manage withdrawal or a long-term basis of use of buprenorphine to manage maintenance with that medication. The special license to prescribe limits the physicians in the first year of their use of the medication to 30 patients. Then it increases over time so that they can manage medication of this sort for treatment of opiate dependence with an increasing amount of ability in their private practice. Buprenorphine is a very effective treatment for opiate dependence. It significantly reduces craving for the drug. It gives people their lives back. They're able to participate in treatment services to manage this very severe withdrawal from opiates and enter into treatment services in much reduced time compared to people going through withdrawal without any medication or utilization of medications to help them to deal with the withdrawal and manage those symptoms initially or in their acute phase of recovery. Other medications can be used too to treat the withdrawal symptoms that occur with the opiate patients. Pain and fever is treated sometimes with ibuprofen or with acetaminophen or Tylenol. Antidiarrheals, anti-nausea medications for their very severe gastrointestinal symptoms to stop the diarrhea, to stop the nausea and vomiting are sometimes utilized. Benzodiazepines, sometimes used on a short period for the insomnia and restlessness and anxiety that go on, but also very much care is taken in the use of those medications in regards to their abuse potential. And buspirone is sometimes used for anxiety symptoms as well. Past withdrawal experiences really increases the amount of anxiety that people feel about withdrawal. People who've gone through this experience before have horrible memories of what it was like and how severe the symptoms were, and that's what generally keeps people using, is avoidance of these kind of withdrawal experiences. So they require a lot of reassurance and support. Everything hurts, everything feels miserable, and until they have resolution of those symptoms, it's very hard to help them look towards a program of recovery. Withdrawal from other substances presents specific physical and emotional problems at times, but not always have the withdrawal from other substances had the same kind of attention or treatment that alcohol, benzodiazepine, barbiturate, and opiates have. Cocaine, methamphetamine, and other stimulants really have no specific treatment, but there are significant changes in mood and appetite and sleep, and levels of depression and changes in anxiety, suicidal ideation. And also with cocaine, there's a possibility of cardiac problems due to the impact that it has on the cardiovascular system for chronic users of cocaine. Marijuana, in its withdrawal, has significant nausea for some people, flu-like symptoms, diarrhea, muscle aches, sleep problems, significant craving and irritability, but generally do not require any kind of medical intervention, just time. As marijuana has a slow release from the human body, the withdrawal symptoms can kind of come and go over a period of time. Inhalants and solvents that are used to huff in order to get high, like gasoline or other solvents, may have need of treatment immediately for intoxication, for overdose or problems with acute intoxication, but generally don't have a specific withdrawal. Generally, long-term effects on the person who uses inhalants and solvents is on the brain function and in memory and cognitive abilities, and in direct effects on the body regarding the type of solvent that's inhaled or utilized. Anabolic steroids, there's not much specific treatment for people who've been abusive of steroids, but there are specific changes in mood, and anger issues are common in the use of those drugs. Club drugs such as hallucinogens or GBH or ecstasy, ketamine, and PCP show changes significant to their mental status and behavior, and yet do not have a specific type of physical withdrawal associated with their use. Nicotine has a very significant withdrawal and craving with abstinence syndrome. It does respond very well to nicotine replacement therapies such as gum and patches, and then are reduced over a period of time, but generally there's a lot of irritability and physical symptoms that go along with nicotine withdrawal. Techniques that we can use to provide a safe and stable approach to withdrawal management includes providing a positive environment with attention to the lighting, the sounds, and the contact that is reassuring and supportive by the staff who are manning the withdrawal management site. Good hydration and nutrition are essential for people in acute withdrawal, making sure that they have plenty of fluids and nutritional foods to eat once their appetite returns, and their withdrawal symptoms that include nausea and vomiting are managed. Hydration is very, very important. Encourage sleep and rest periods of time is also very important in the recovery from withdrawal from drugs and alcohol. And involving people in purposeful activity, physical activity is tolerated, is important too. Walking and being up and about, and not just lying in bed and feeling miserable, but being involved in something that's purposeful can help people in the adjustment from withdrawal to feeling better physically. Communication is very important when working with people in withdrawal, though. It's very important that you examine your own beliefs and attitudes about drug and alcohol abuse. Working as a team is vital in transferring information from one shift to the next, or one group of people to the next if you're referring someone to the hospital or to a physician for assessment. Learning to manage your own frustration and anger and sadness is very important as well, and ventilating those feelings to peers and to others that'll help you to understand and to cope with those feelings that are so often associated with dealing with this population of patients. It is a very challenging group of people to work with. There's great recovery, but often working in just the withdrawal aspects or incarceration aspects, you don't always get to see the recovery aspects when people get involved in treatment services and turn their lives around. Because they're no longer seen in a jail then. They're not breaking the law. They're not doing the things that were so much a part of their drug use or their alcohol use if they find recovery. So it's very important to work within the understanding of the people that you work with, that you see and not at their best, can be very frustrating and very sad, for the can lead to burnout unless you take really good care of yourself. A major aspect of any kind of treatment of withdrawal management or dealing with people in these types of situations is the documentation standards that are developed and utilized in your facility. Clear, concise records that are legible and contain only approved abbreviations are very vital. Include details in verbal and written reports that others can utilize in providing ongoing care for clients. All documentation should be done in a timely manner and should be signed and dated in the time noted by the author. Any correction should be clearly identified, and errors should have only a single line through them and be clearly legible. Whiteout or erasures are never permitted in a legal record. Successful withdrawal management, then, is a process that can be measured in part by whether an individual who is substance dependent enters, remains in, and is compliant with the treatment protocol of a substance abuse treatment or rehabilitation program after they have achieved detoxification. We want to make sure that people who are seen safely through withdrawal get help to change their lives and their misuse of drugs and alcohol. Very important that we have a mechanism to refer people or to have them assessed during the time that they're in withdrawal, regardless of where that facility is and where they are in the process, so that they can be given a successful kind of referral to appropriate treatment services. Once an individual passes through the most severe withdrawal and is safe medically and stable, the focus should be on then this psychosocial intervention that shifts for preparing the patient for substance abuse treatment. Assessment of the patient's characteristics and strengths and vulnerabilities that will influence the recommendations for substance abuse treatment is established in those ASAM criteria format that we talked about earlier in this presentation. Preparing the patient to participate in treatment is really important, and successfully linking the patient to treatment as well as other needed services and resources in the community are very important as well. The next slides provide you with information to obtain free copies of treatment improvement protocols and products that are available through our federal government that you can access free of charge, that will give you significantly more information about the treatment of withdrawal and the referral sources available in your state and in your community. This slide, the detoxification of chemically dependent inmates from the Federal Bureau of Prisons, the clinical practice guidelines, are a very important source of information. The actual forms for the CWA and COWS and the benzodiazepine assessment tools are included in these documents as well. Very important for you to access those sources of information as you develop your approach to withdrawal management in your home facility. My contact information is presented in this slide. For further information and assistance in development of your program, please contact the Heartview Foundation in Bismarck or in their Candu location, or contact Community Medical Services at their Fargo location or in their Minot location. Thank you very much.